Happy New Year and welcome to our first webinar of 2019. My name is AJ Scheitler and I am the Director of Stakeholder Relations here at the UCLA Center for Health Policy Research, and I am very happy to introduce today's seminar, Improving California's Behavioral Health Workforce for Older Adults. Now, before we get started with today's presentation, I want to let everybody know about next month's webinar, Reducing Access Disparities in California by Ensuring Low-Income Undocumented Californians. On February 19th at the same time, 12 noon, we will be discussing a new report. It looks at the fact that the Patient Protection and Affordable Care Act did not extend eligibility for health coverage to undocumented populations, and federal policy prohibits the coverage of undocumented individuals under Medicaid using federal funds. However, California has extended Medi-Cal, the state's version of Medicaid, to undocumented children using state funds, and efforts are underway to expand eligibility to the state's adults. Using the latest California Health Interview Survey data, Associate Center Director Nadira Parat and her co-authors reveal the demographics and characteristics of this undocumented adult population, how their access to care compares with their documented counterparts, and the implications of extending Medi-Cal eligibility to the last remaining uninsured population who have very limited coverage options. So again, that's February 19th at 12 noon right back here. Now, for today's presentation, as always, at the end of the presentation, we will have Q&A. If you are with us online, please use the chat feature to ask your questions, and we will save them for the end. A video is being made of this webinar, and it will be made available at the address that you see on your screen. And if you would like copies of the slides from today's presentation, please reach out to Venitia Lai. Her email address is on the screen as well. And now for today's discussion. Did you know by 2030 there will be more than 9 million older adults, that's over the age of 65, here in the state of California? There are about 6 million now, according to an estimate by the state's Department of Finance. That means 1 in 5 Californians will be older than an older adult by 2030. Now, we already have gaps and deficits that exist in the state's workforce for geriatric mental health care. And these will only worsen as that population expands. We need to expand the workforce and have better training for older adult behavioral health needs. This is according to a new study that was released last week by Center Faculty Associate Janet Frank and Research Center Scientist Kathryn Kietzman. In today's webinar, Janet and Kathryn will discuss their findings about the state mental health workforce and share recommendations on how state policymakers, educational institutions, and county mental health and behavioral health departments and their contracted providers can help improve this workforce and ensure that training addressing the specific mental health and substance misuse needs of older adults is made a priority. So today's seminar, let's get started, Improving California's Behavioral Health Workforce for Older Adults. Dr. Frank. Okay. We've got our technical issues solved. Thank you so much for joining us today. We're very excited to be able to present about our most recent work around California's behavioral health workforce for older adults. What we're going to cover is, first we're going to provide some background about the Mental Health Services Act, the older adult behavioral health needs, and workforce gaps. We'll then go into our report methods and end with plenty of time for discussion on our recommendations for improvement. The Mental Health Service Act was actually passed in 2004, and it is also known as the millionaire's tax, since it is a surtax
that's levied on California residents who make more than $1 million a year. The goal of the Mental Health Service Act was to transform public mental health services for the seriously mentally ill to a recovery and resilience model. To date, over $15 billion has been collected in this surtax and provided to public mental health services. When the Mental Health Service Act was designed, it had a number of components. It, of course, had direct services to seriously mentally ill. It also provided prevention and early intervention programs. Importantly for our talk today, it provided funding for workforce education and training, also known as WET, W-E-T. And it also provided funding for innovation projects, many of which focused on integrative care and other kinds of innovations that have been shown to improve mental health services. To dive a little bit deeper into this WET component, the WET funds are split between the state and all counties. And state funding included statewide programs such as student stipends, loan forgiveness, and grants for education. Even grants to people, general public peers, who wish to have further education and training around behavioral health. The counties spent their funds based on local needs assessments and included some training about older adult behavioral health. We'll talk a little bit more about that later on in the presentation. Interestingly, WET funding ended in June of 2018. It sunsetted, and so currently there is no funding for continued WET programs in the state of California. The Office of Statewide Health Planning and Development, or OSHPD, manages the WET component and also is tasked to develop the new WET 5-year plan. And OSHPD has been going through this process for the last, I would say, good year. And they used a very robust planning process to gather information to develop the next 5-year plan, including evaluating the current WET programs, hosting focus groups and key stakeholder meetings, working with the California Behavioral Health Planning Council, which is required to improve the plan. The council has both an employment and workforce committee and a WET steering committee, which Kathryn and I are both on. Because there are no WET funds right now at this time to support new activities in the 5-year plan, the plan that was passed just last week by the council is more of a blueprint to be fleshed out over the next year as funding is identified to support behavioral health workforce activities. And we were able to provide input into the plan. We gave OSHPD a number of suggestions on how to improve the plan, and then very recently we were able to share an advanced copy of our policy brief, and then we were at several of their meetings where they reviewed the plans, and we were able to make our recommendations to them about strengthening the plan around older adult behavioral health. We also plan to continue working with OSHPD as they continue their plan development over the next year. So what is different about care for older adults? Why do we need special types of training for behavioral health workers? Well, 1 in 5 older adults have behavioral health problems, depression being the most prevalent. And depression is not a normal part of aging and needs assessment and treatment, which often goes unprovided. The other types of behavioral health problems are listed here. Anxiety disorders is quite prevalent. Post-traumatic stress disorder, bipolar disorders, schizophrenia, many of who have aged into older age with schizophrenia. Substance use disorders is a major issue, especially for the upcoming older adults that grew up in the drug, sex, and rock and roll era. And depression and behavioral problems secondary to dementia. Suicide rates are very high for older adults. Men aged 85 and over actually have a suicide rate that is 4 times higher than the rate of any other age group. So on the other side, when you combine that with the medical needs, most older adults have very complex medical needs, and about 80% have at least one chronic illness, and 77% have more than one. So our vision for behavioral health, improved behavioral health workforce, is that with a well-trained and competent workforce, we can increase the quality of care and lower costs. There was a landmark study in 2012 that led to this report by the Institute of Medicine and the National Academies, the Mental Health and Substance Use Workforce for Older Adults. Here is a quote from this report. "The workforce is not prepared in numbers, knowledge, and skills to care for the mental health and substance use needs of a rapidly aging and increasingly diverse older adult population." When we look at the types of people that are working in the behavioral health workforce, we see a number of categories. Peer workers with lived experience, direct care workforce, primary care physicians, psychiatrists, psychologists, licensed marriage and family counselors, social workers and case managers, and of course nurses. Currently, there's about 80,000 licensed behavioral health professionals in California. When we look at the gaps in the specific types of clinical providers, we see that we have about a little over 3,000 psychiatrists in California, and most of them practice in large urban areas like Los Angeles and the San Francisco Bay Area. Very few are trained in geriatrics. In fact, there's less than 1,800 geriatric psychiatrists in the entire United States. When we look at other types of licensed clinical professionals, we see the same picture. Very few nurses, it's estimated to be 1%. Very few psychologists, 4%. Very few social workers, estimated at 4%, have training in and specialize in geriatrics. And only about 3% of medical students take any type of geriatrics elective during their training. Physicians do have an opportunity for postgraduate fellowship, becoming a certified geriatrician, and currently there are only 720 certified geriatricians in the state, many of them here in Los Angeles, and we do have a great program here at UCLA. When you think about ethnic and racial representation, this is also an issue for several of the professions. For example, African Americans and Latinos are underrepresented among both psychiatrists and psychologists. Back in 1995, the Bureau of Health Professions at the federal government published a landmark report called the National Agenda for Geriatric Education. That was 24 years ago. And sadly, not much has changed in almost a quarter of a century. So why don't more people choose geriatrics? Well, a big issue, I believe, is ageism. There's a lot of stigma in not wanting to work with older adults. There is very little requirement for geriatrics and gerontology in higher education. Extra education and training are required, and there is a lack of policy support, such as specific types of stipends and loan forgiveness. So at this point, I'd like to turn it over to my colleague, Kathryn, who's going to walk us through some of our study methods.
Thank you, Janet. So to learn more about the status of the geriatric mental health workforce in California, we used data and findings from a recent study we conducted that investigated how older adults were being served by California's public mental health system. We also conducted an extensive review of the literature. The Older Adult System of Care study was funded by the California Mental Health Services Oversight and Accountability Commission using Mental Health Service Act funds. And it was the first study since the passage of the MHSA in 2004 that assessed the impact of MHSA dollars on older adult services. And this study included secondary data. We reviewed 100 reports and analyzed 35 in-depth. We interviewed 72 key stakeholders across the state and counties. 6 counties were in our study sample. 13 of the stakeholder interviews were at the state level and 59 were at the county level. And then we also conducted 6 focus groups with 44 participants. 33 were older adult consumers of public mental health services and 11 were family members. Finally, we surveyed all counties to assess the current status of an older adult system of care at the county behavioral health level. The literature review for the current study focused more specifically on the geriatric mental health workforce issues. We used both peer-reviewed and gray literature, including unpublished national, state, and local level evaluation studies and other publicly available documents. So what we learned from our older adult system of care study is that WET funding for geriatric education and training ranges from short sort of one-off programs for staff. Typically these are a half or a full day and they're administered every 3 to 5 years, to more extensive training programs, such as an example provided in San Diego, where San Diego State University developed an Academy for Professional Excellence behavioral health training curriculum and launched a 6-month certificate program for clinician case managers in the county behavioral health departments who provide clinic-based services to older adults. And this training is sort of at the level of a college level course, and it provides specialized training and creates an incentive for clinicians in public mental health to assume and maintain an older adult caseload. Findings in our older adult system of care study echoed what we found in the current literature review. Very few counties had clinical staff trained in gerontology or geriatrics. We also found that there were great geographic disparities between rural and urban counties in California. Urban counties, as Janet mentioned, had more behavioral health workers on average, and more of them had training in geriatrics, although these still were not substantial numbers. Rural counties often relied on student trainees, and these were students who were getting stipends and or loan forgiveness through WET, and they were fulfilling a service requirement. Once their service was completed, they often left for other places that had higher paid positions. And this created has created sort of a revolving door of trainees. This creates a lack of continuity of care for older adults, clinicians without expertise or knowledge about special needs of older adults, and gaps in service availability due to recurring and prolonged vacancies in many counties. Very few, if any, of the trainees had taken specialized coursework in geriatrics. One of our study participants described these disparities sort of a zip code lottery, meaning that the services that an individual has access to and the availability of providers really depends largely on where you live. To drive home the importance of addressing California's workforce shortages, the shaded portion of this map shows that 207 defined geographic areas in California are federally designated as mental health professional workforce shortage areas. You can see that very few counties are not so designated, and actually all rural counties have this designation. This map shows that mental health professionals tend to cluster in large urban areas like Los Angeles and the San Francisco Bay Area, further compounding the problem for the rest of the state. Those are the only areas you'll see on this map that are not shaded. So while this map illustrates the mental health workforce shortage areas in a general sense, what we don't know from this map is the extent of workforce shortages that are specific to behavioral health specialties, such as the availability of providers with expertise in geriatrics. So through our earlier study and the more recent review, we've learned that there is no state requirement for this type of workforce data, even for state-sponsored programs. While some counties do collect and report these more detailed workforce data, it's really ad hoc, it's not universally available, and it's not currently required by the state. So based on these findings from our earlier older adult system of care study and from our more recent review, we have a series of recommendations we'd like to share with you of how California can better address mental health professional workforce shortages with special attention to the needs of older adults. So our recommendations are organized really at three major spheres of influence. One is the California legislature, state agencies, and policymakers. The second are institutions of higher education, accreditation bodies, and licensing boards. And the third are county mental or behavioral health departments and their contracted service providers. So at the state level, we strongly recommend that in its next 5-year WET plan, the Office of Statewide Health Planning and Development include a county requirement for priority slots in future loan forgiveness and stipend programs for trainees who are interested in geriatric behavioral health services. In addition, rural shortages could be better addressed through this plan if there are increased funding allocations and streamlined program application processes for rural and frontier counties who are already really taxed to develop and to participate in these administrative processes and these often complex applications. Finally, the state is really well positioned to develop a more robust data collection system for WET trainees and sponsored training content, for example, in geriatric behavioral health. Ideally, data collection at the state level would include some specifics, things like availability of provider types and specialties across counties, MHSA-funded behavioral health education and training programs, professional attendee characteristics, the number of people attending these programs, and importantly, the training and organizational outcomes that result from these training programs. Other state-level recommendations include promoting peer support programs and expanding training efforts to develop and implement a geriatric behavioral health curriculum in all counties. Peer support specialist programs are currently offered in 47 states. The California legislature passed a bill last year after many years of effort to create such a program, but unfortunately Governor Brown vetoed it. It was the Senate Bill 906, and it would have established a certification program that sets statewide standards, including required training with a consistent curriculum, continuing education, practice guidelines, clinical supervision requirements, and certification protocol. In addition, the bill would have authorized the Department of Healthcare Services to amend the state's Medicaid plan and to add peer support providers as a provider type within the Medi-Cal program, and to seek federal waivers or state plan amendments as necessary to support this new classification of worker. We learned from the older adult system of care study that peer support programs for older adults are highly sought after by the consumers of care, and they're very effective. These programs may be especially useful in addressing generational or cohort differences related to the stigma that many older adults experience when seeking and accessing behavioral health services. The intent of peer programs to provide increased family support, a fuller continuum of wraparound services, and an individualized focus on clients to promote their recovery and self-sufficiency are all highly relevant to efforts to address the needs of older adults. Peer certification legislation is highly likely to be reintroduced in California this year, given the groundswell of support from numerous stakeholder groups that are committed to this effort. We anticipate or hope that our new governor may also be supportive. Finally, at the state level, the California Institute for Behavioral Health Strategies is currently contracted by the Department of Health Care Services to provide training to counties and technical assistance for consumer and family member employment. Department of Health Care Services could direct the CIBHS to utilize some of that funding to develop and deliver a geriatric curriculum and further develop the local workforce to be more responsive to older adult behavioral health needs. So now I'm going to return the podium to Janet, who's going to talk about recommendations for some of the other spheres of influence.
So these are recommendations for institutions of higher education, colleges and universities, accrediting bodies of behavioral health workforce, and licensing board for licensed behavioral health workforce. And this is kind of approaching it from a two-prong approach. We need to provide training to the current workforce who did not have the benefit of training and education when they were in school. And these recommendations really focus on making sure that we address the knowledge and skills gaps of future workforce by providing better content in colleges and universities. And so we do recommend that geriatrics topics be included in the core curriculum of colleges and universities. Currently, most of these are offered as electives. And as we mentioned before, sometimes somewhere between 1% and 4% of the behavioral health workforce types of students will take advantage of those electives. So we need to have these as core required content for the helping professions. In addition, we would recommend that colleges, probably community colleges and places like University Extension, develop career technical education programs and peer education programs for the peer specialist and paraprofessionals in geriatric behavioral health. For the accreditation side, we have seen in other professional development efforts, such as geriatric medicine, that when questions are being asked during the curriculum review process of accreditation about whether or not there are competency expectations around a certain area, that schools pay attention to this. So we would suggest that geriatric behavioral health expectations be a component of curriculum review during the accreditation process. Another way we've seen increases in content in these very busy curriculums is if questions get put on licensing exams. So we would suggest that the different licensing entities include questions about key content in geriatric behavioral health linked to competency standards. We think that these will increase the likelihood that content will start being required and part of core curriculum. When we look to the county behavioral health departments and contracted service providers, we know that their type of training is driven by the local needs assessment process. In our previous study, we found that older adults and veterans are the fewest numbers and the least likely to participate in planning processes at the county level. So we would encourage counties to utilize this kind of data, knowledge that there is a vast need, and develop and implement incentivized programs for clinical staff to gain the competencies in the behavioral health service areas. We need more behavioral health clinicians with geriatric training, and this can be done by either priority hiring of well-trained professionals with this expertise or training people with this expertise once they're on the job. As Kathryn mentioned, the San Diego training, Los Angeles also has a great training program linked with the UCLA psychiatry department, and other counties also have other model training that's described in our previous work. We would also recommend that counties develop peer training programs that involve people with lived experience to provide culturally appropriate auxiliary or additional behavioral health services for older adults and others with complex medical needs. Counties can use professional development programs, and after completing the specialized training, then clinical staff could get higher salary classifications as older adult specialists across the provider categories. And this would really help to fill that kind of position. That's what they do in San Diego. So in conclusion, addressing the deficiencies identified in California's geriatric behavioral health workforce will require a concerted and multi-pronged approach or approaches. And although the problems have been identified for decades, there has been very little, if any, improvement, even with this massive infusion of MHA wet support. The expected increase in the number of older adults who will represent nearly 20% of the state's population by 2030 necessitates action for improvement now. So what will it take? It will take leadership at every level. It will take your involvement as listeners and stakeholders in this process. It will require political will to accomplish the recommended course of action. We're very lucky to have been funded by the Archstone Foundation for this work, and part of their grant was to provide funds for us to take our recommendations kind of on the road and have a number of meetings with key decision makers and planners to promote the recommendations going forward. The timing is good to create new opportunities because of the wet planning process. And we think that we can make some impact to increase the geriatric behavioral health expertise of the workforce. So our policy brief, for those of you in the room, you have it on your table, but if you would like to grab it off the web, this is the address. And I'll leave this back up after I finish saying a couple more thank yous. I'd like to thank our co-author, Alina Palomaru. She is an associate policy researcher at RAND Corporation. And I would like to thank our reviewers of the policy brief, Jane Adcock with the California Behavioral Health Planning Council, Margaret Merritt and Adrienne Shilton with the Steinberg Institute, and Imelda Padillo-Frosto and Steve Wallace here at the center. I also want to thank and acknowledge Archstone Foundation, who has funded this particular work. So thank you very much. Now we will open it up for questions and comments, and I'll just back up and leave that link here for those of you that want to copy it down. So what questions do we have? And Kathryn, maybe you can come up.
Okay, thank you very much. The way that we will handle this, we will, thank you very much.
Sorry.
The way we will
All right.
handle the Q&A
now
period-
everyone can hear me. The way we will handle the Q&A period is we will go back and forth between questions in the room and questions from our online participants. As a reminder, if you have a question and you're joining us online today, please utilize the chat function and we will get to hopefully all of the questions. We will start with the room. Does anyone in the room have a question for our authors today? Just if you'll start by your name and if you have any affiliation.
My name is John Holmdahl. I'm with the World Synergy Institute. Question is, when Governor recommendations, what was his reason for doing that? Recommendation.
The peer specialist.
Yeah, well, to clarify, those were not our recommendations. There's an organized group of stakeholders who've been working on that for some time. I honestly I couldn't answer that question, unfortunately, why he chose to veto it. Everything had gone through and passed in the by the legislature. But it could have been.
We don't have any questions online yet.
Any number
we have
of
another
reasons.
question in the room.
Sorry. Yeah.
We don't have any questions.
Thank you. Great report. Peggy Toy, I'm here at the center, our health data program. Can you talk about the recommendation for the peer training program and for people with lived experience to provide additional support? Can you talk more about that and what that looks like?
And especially, there's some great models around geriatric peer counselors. So currently, there are a number of programs around that that have a very structured curriculum, and they train peers and people with lived experience. So this may be family members or clients themselves. And what they do is they then offer support classes and other kinds of peer-to-peer programs for as an adjunct to the other types of services being offered by agencies. And so we would like to, one of the peer specialist program is really trying to standardize that kind of work, but these peer counseling programs and other kinds of peer-to-peer types of programs have been around for quite a while. Would you like to add to that?
And I mean, just a more specific example from our older adult system of care study, they have what they call the pool of consumer champions in Alameda County. And these are not limited to older adults. They have all kinds of different groups that have some sort of common characteristic. But the Alameda County, they've actually hired peers to be part of their administrative unit in the Department of Behavioral Health Services. So the broad idea is that you can draw from peers who have the lived experience, whether it's the consumer or the family member, and they can bring that to expand the workforce in a way that's more, in many ways, perhaps more responsive and that consumers can more readily identify with those individuals than perhaps with a professional per se.
You mentioned that San Diego County in some of their settings were able to increase pay if you had a certification for working with older adults. Did you find any other programs, either in California or outside of California, that you're aware of, to find other ways to incentivize more people to go into geriatrics from the beginning?
Well, I know in Los Angeles County that one of the things they've done is that they have earmarked a number of the slots for their stipend programs to be filled with people that have interest in geriatric behavioral health. So say they have, 20 slots that they're going to be issuing, then maybe 5 of those would be earmarked for the students that have expressed that kind of interest. So we would like to see other counties build on these models to be able to increase their own expertise, their workforce's expertise in geriatrics. But we did not run across, as far as I know, we did not run across any others that had actual pay increase components that are linked to the training.
Do you have any more questions in the room?
But again, it's a model that could be used by others.
Hi, it's Imelda Padilla Frausto from the center. You talked about students going out to rural areas and kind of giving back their time for loan forgiveness, and then once they're done, they leave. Do you have any suggestions for how these rural areas can retain these students or retain the workforce in these areas, or have you come across any successful models that have done so?
The workforce. There's kind of a movement, it's kind of coined as grow your own. And so what they've been trying to do is to do more around building interest in working in the behavioral health workforce through education and awareness building in the communities, and trying to get more of their own local residents to become involved in this. I think that the other issue is the issue around payment and salaries. And so if the rural counties that are really stretched in so many different ways, if they were given some type of differential funding to be able to increase the pay, then people may not be so likely to leave. Typically, the loan forgiveness requirement is a 2 years of service. And I know that data from OSHPD, as they looked at their previous WET programs, showed that after the completion of their service, that the trainees tended to stay in the public mental health system working for an additional 2 years, although it may not have necessarily been in that rural, hard-to-place area. They didn't have that kind of data. So it equals about maybe 4 years of return in the public mental health system. Did you have a suggestion?
I don't remember that we found this in our study. Maybe you do, but certainly colleges, community colleges, and universities in the rural areas could be a launching point to get those students supported. But then they already have roots in the community to perhaps stay on. So again, working with the local rather than recruiting people from somewhere else might have promise.
Hi, Nina Ponce from the Center for Health Policy Research. First of all, congratulations. This is a really comprehensive, well-done study. And I also like the multitude of recommendations that get at the pipeline and trying to also solve the incentives right now. So one recommendation I didn't see is working with health plans, or say working with Covered California, or like trying to incorporate this from a plan or contracting accountability to ensure that particularly the rural areas, for example, some of the 19 regions, which are rural areas, that there would be an additional incentive that the plans that we contract with, say, Covered California, would ensure that there is this preparedness and competence for geriatrics.
Yeah, I think that's a great overlooked recommendation here. So thank you for raising that. I think that there are within managed care plans, there are opportunities there. They also have their own struggles with getting geriatric specializations, and so that would be something to look into. And it would really, I think, depend on how that health plan or any of the health plans are interacting with the public behavioral health system, because it's traditionally been carved out. And so I think it would be finding opportunities that would serve both that managed care plan or those health plans and the county behavioral health system, so that to sort of bolster and support developing that workforce across the board, and finding ways where they can
Any final questions
identify points of synergy.
or thoughts from the authors? Okay, well, thank you all very much again.
Okay, well,
Thank you all for joining us online.
and thank you all for joining us online. We just remind you that on February 19th, we will have our next webinar. It's back here at 12 noon.